Hi, Lawrence LeBrocq, Managing Partner and CEO of Garces, Grabler, and LeBrocq. Welcome to Victim to Victory, Triumph Over Tragedy. Today we have an incredible guest with us. We have Dr. Joshua Landa from Landa Spine, one of the top surgeons in the state of New Jersey and actually the tri-state area. Welcome to the show, Doctor.
Thank you. Thank you for having me.
It's my pleasure. I want you to tell us a little bit about your education before we go into all the wonderful things you do and how you help people nowadays. But tell us a little bit about that neurosurgery and orthopedic fellowship, because that's very unusual. So just tell us a little bit about that background.
Yeah, historically, neurosurgeons and orthopedic surgeons used to operate as like distinct teams. The neurosurgeon would handle the plumbing. They would take away the pressure from the delicate nerve roots, while the orthopedic surgeon would handle more of the carpentry aspect of it. So screws, rods, cages, things like that. And they worked as a team in order to help patients. This is like back in the 90s. Over time, a lot of us have gained the ability to work as an independent person treating the spine on our own. So by completing the formal fellowship in both disciplines at the Cleveland Clinic, I'm able to see the spine through a unique 360-degree unified lens. And in a courtroom setting, I think this makes my testimony more resilient under cross-examination. So like opposing counsel may have a tough time boxing me into a single specialty or to claim that I'm ignoring either the neurological components or the orthopedic components, where I'm considering everything. So the extra training really does help me bring expertise from both fields, from both perspectives, into the field of spine surgery.
Well, that wasn't enough. Then you had to get an extra degree, or you studied a fellowship also in biomechanics?
Yes, so this was between my second and third years at NYU. I took an extra year to pursue the research-based orthopedics biomechanic fellowships at NYU. So we spent our time that year in the biomechanics lab utilizing special motors and actuators to place physical loads to compress, to pull on human tendons and spinal columns in order to find their mechanical breaking points. Because I physically measure these forces, I feel like that gives me a unique perspective to explain to a jury exactly what happens in a rear end collision or other auto accidents. So like when a vehicle is struck from behind, the occupant's torso is accelerated forward violently, but the head lags behind. So this causes the neck and spine to act like a whip, which can multiply the forces that are applied to the discs in the neck. A good analogy to it is like a rubber tire, right? When a sudden asymmetric force, like a big pothole or something like that, hits the tire, there's so much force on the tire that it can cause the rubber to rip, and the outer wall can no longer contain the pressure. Which is similar to what happens to a disc in an accident. So the biomechanical training really allows me to bridge the gap between bent bumper and the structural failure of human tissue.
And just to talk about that a little bit, a lot of times you're going to get you'll have, the defense will try to state that because somebody's head did not strike either the steering wheel or necessarily the headrest, they try to claim that you can't have a closed head injury or a concussion. And tell us why that's not accurate.
Yeah, I mean, it's one of the most basic ideas in neurosurgery that there's something called a coup and a contrecoup injury. So when the body is seated in the car seat, the head is usually not connected to the headrest. So the sudden acceleration and deceleration forces on the body move the torso, but the head remains in place by inertia. And that can cause rather violent injuries to the head without necessarily impacting the skull. Sometimes it can be even worse. So there are certainly there are people who have died without hitting their heads just from the violent acceleration and deceleration forces. So it's well documented and well known that You don't necessarily need to impact your head on the steering wheel, the windshield, in order to have a rather serious injury to the head and neck.
Now, you're so well educated and so very intelligent. Sometimes you're dealing with lay people on a jury when you're trying to explain the anatomy. So how do you simplify and explain to a jury the anatomy when there's such terms as radiculopathy, spondylosis, spondylolisthesis? How do you go through all of this just to get it to where a layperson will understand?
Medical jargon has no place in the courtroom. If we use these excessively long Latin words like spondylolisthesis, right, it's ridiculous. Just because we learned this term in medical school, what's going to happen is the true meaning of the patient's injuries and the suffering that resulted from those injuries just gets lost in translation. So my strategy is to communicate simply and visually. If a patient suffers, let's say, from spondylolisthesis and foraminal stenosis, I don't expect the jury to memorize those terms. I tell them the spine has become loose and it's out of alignment, and that the nerve has been choked off as it exits the spine. And when you give the jury a clear, relatable picture of what's going on, I feel they can instantly connect with the medical reality. The concepts underlying what we do aren't complicated, and if we cloud them with extra long words that are completely unnecessary, all we're doing is causing the jury to not understand what we're saying. And if they don't understand it, they're just going to discard it.
Yes, I've tried a few cases in my day, as you know, and you see a lot of times where you'll have brilliant lawyers just using words that an average person on a jury is not going to understand, and you see doctors doing that, and you get that look on the jury like they just glaze over because they're not understanding, and it's not because they're not intelligent; they just don't use this language every day.
Exactly. You don't add anything other than making yourself feel smart by using, a Latin word with 87 letters in it. You don't need to say spondylolisthesis. You can just say that the spine had slipped out of alignment. And I think you can convey the message quite effectively that way.
What are some of the tactics that you do not find to be effective when being cross-examined by a defense lawyer?
I think the biggest mistake that a lot of defense lawyers make is that they spend too much time just working with defense attorneys, with defense experts.
Right.
And I think what they do is they try to isolate these unique data points and look at some piece of information in a vacuum. But that's not how we're trained in medical school. We're trained to look at everything, right? We look at the history, we do a physical examination, we look at the imaging studies, and we put it all together and see how things correlate. And that's really the key to understanding patients, whether they're in an accident or not. So I think, honestly, the defense often starts with a cynical assumption that the plaintiff's exaggerating or lying. And I think that's really at the heart of a lot of their misunderstanding. And that violates everything we're taught as physicians. In medicine, you don't diagnose an MRI film. The first thing you do is you talk to the patient, you do a physical examination. So you're not looking to diagnose an MRI, you're looking to diagnose a human being. So we're always taught to first start with the history. You don't put the MRI first. If you have a medical student, they put up the MRI, they take it down. What did this person say? What was the physical exam? And then after you have the conversation and after you do a physical examination, then you look at the image. So when, like for instance, the defense will often claim an injury is purely degenerative, right? So I can protect my position by looking at the entire integrated clinical picture. So one example I often give to kind of hammer home the point is I'll say, this person was living a completely normal, functional, pain-free life for, tens of thousands of days. And then an accident occurs, and immediately afterwards, there's sudden, severe pain that matches the physical exam, that matches the MRI. So the MRI can show us the anatomy, but the clinical correlation can show us the causation. So you can't separate these two, and you need to look at the picture as a whole. And I think when you do that, you really do get to the heart of the matter.
Right. And now we're talking a little bit about the asymptomatic plaintiff, a person who's not suffering from any pain, but none of us are pristine. We start degenerating from the young ages, maybe some people say in your late teens, early 20s, but we all start to degenerate to some degree. So you may have a bulging disc, you may have a little growth on one of the end plates in your spine, but if they're not bothering you, and then you have this accident, how do you debunk because we all know, you've been through enough trials, the defense, it's always the same. It's either not there or it's pre-existing, so it's never causally related to the collision that occurred or the trip and fall that occurred.
Exactly. Yeah. I mean, I like to use the analogy sometimes of like a suspension bridge with a crack in it. Okay. And every year, thousands of cars drive back and forth over the bridge. The crack's there, but nothing happens. No issues. The bridge is perfectly functional. It's doing its job. It's ferrying its passengers. No issues. But one day, someone doesn't read the sign and drives their 80,000-pound, overloaded truck, tractor trailer truck right over the bridge, and boom, the bridge collapses. So it wasn't the structural crack that caused the collapse, but it did represent an underlying vulnerability. So you need to subject that crack to a violent, extraordinary, unanticipated force, at which point it has no choice but to fail. So that's kind of what happens in the asymptomatic spine. The pre-existing structural weakness, the mild arthritis, presents like a vulnerability, right? It predisposes the spine to failure. So the defense wants to litigate the crack that never bothered the patients, and I'm here to show the jury that the collapse was caused by the trauma.
Right. So we're dealing now, a lot of times, we have objective data like the MRI, and then you have your subjective complaints. How do you weave those two together?
Yeah, again, it comes down to treating the patient rather than just the picture, right? In my practice, right? I mean, most of the patients I treat are just there, for help. They weren't necessarily involved in an accident. If I see a massive dramatic disc herniation, but the patient's comfortably sitting in front of me, they don't have any pain, they only came to see me because someone told them that there's something wrong in the MRI, I tell them to go home. They don't need surgery, right? I see patients like that. Conversely, someone can have a smaller disc herniation that's pushing just right on a very sensitive area of the nerve, or into an area that was already narrow beforehand. Some people are born with a narrow spinal canal. So if that small herniation perfectly correlates with the overall picture, then the clinical reality can be undeniable. Like it's like a small pebble, right? The analogy, if there's a small pebble in your shoe, it can make it impossible to walk. So a small herniation in the right spot in a tight spinal canal can cause agonizing, debilitating pain. And that's the way I look at it.
Now, by trade, you're a surgeon. Let's talk about some of the changes in techniques since you've been a surgeon, and talk a little bit about minimally invasive. And sometimes people hear minimally invasive, you're still being cut open. It's just not as big a hole as they used to do in traditional surgery. So explain a little bit about what is minimally invasive surgery and what do you perform and why?
Yeah. So minimally invasive surgery, sometimes people call it like minimal access surgery. So what we're trying to do is make a smaller incision to get to the spine. But when we get there, we still have to do what we have to do, right? So, people think minimally invasive is a minor surgery. I mean, there's no minor spine surgery. The surgeries that I perform, I'm permanently removing ligament, bone, and disc from the human body. I'm operating less than a millimeter away from major spinal nerves that if they are injured, they can never be repaired or replaced. So, think of it like a heart surgery or a modern heart surgery where the surgeons go in now and repair a damaged valve using, a tiny catheter through the wrist or the thigh. No one would call that a minor heart operation. the size of the opening doesn't change the high stakes reality of the work that's being done on the inside. The x-rays still have screws and rods and cages. The anatomy is permanently altered. So regardless of the size of the incision, we're permanently altering the structural mechanics of the spine. And that's what I tell patients in the office. I tell them, I'm going to do this minimally invasive, but this is a maximally important operation you're about to undergo. And there are risks and there's recovery and there's no guarantee. And I think patients understand that.
Well, explain the difference in some of the surgeries you perform. We deal with this every day, so we understand the difference between a discectomy, foraminotomy, then you have your fusions, and you have disc replacement. So could you just go into a little bit about the differences, and when is one required and when is one better to have than another?
Yeah, it's a great question. So generally speaking, if the problem is just some disc that's pushing on a nerve and the rest of the disc looks salvageable, then we can go in and just clean off that portion, take away that piece of disc that came out of place, relieve the pressure on the nerve, and relieve the radiating pain, which is a smaller operation comparatively. Unfortunately, if the disc itself has been injured to a certain point where the whole disc is damaged, you can't just cut a piece out. It's kind of like if you have a hole in your couch. There's nothing you can cut out to make the problem better. You need a new couch. So, again, if it's a patient who has a relatively preserved disc and the issue is simply the pressure on the nerve, sometimes we can remove that piece of nerve that came out of place, take the pressure off the nerve, and reduce the leg pain. But when the whole disc is damaged, sometimes you have no choice, and it's causing a lot of back pain. Sometimes you have no choice but just replace it and take out the remaining disc and put in a cage and put some screws there.
Now, when you say put in a cage, put some screws, explain what the purpose of the fusion is. Why can't you just remove the disc? Why do you have to cage it? Why do you need the screws?
Yeah, that's a great question. So there was a technique actually before my time, like in the 70s and 60s, where some surgeons, like in the neck, would just take out the disc and push the bones together. And they said, hey, it's simpler. Just take out the disc, take the pressure off the nerves, remove the painful disc, squeeze the bones together, let them heal. You should be fine. That didn't work. What we learned is that you need to not only remove, if you're going to remove the disc, you need to restore the spine's normal anatomy. There's supposed to be a space there. So if you collapse that space, what's going to happen is you're going to shorten the spine. And when you shorten the spine, you're going to pinch the nerves because there isn't enough room when you shorten the spine, and the outcomes are not good. So we do need to insert something in the spine to fill that gap and try to restore the normal height and curvature of the spine. And the screws are necessary to solidify that, to hold it in place while the body heals.
Now, what's always been curious to me, and I've actually had a fusion recommendation, but I've never had it done because of the likelihood of adjacent segment, syndrome. Explain a little bit about why that occurs and how often that occurs.
So normally in the spine, every segment moves from your head down to your tailbone. They all move together to allow you the normal motions of like picking things up, sitting down, getting out of bed. But if one of those segments is damaged and a surgeon has to remove the disc and fuse it, the motion there is gone. And when the motion there is gone, if you want to bend a certain amount, well, something has to take up the slack. So what happens is the discs in the rest of the spine, in particular the discs above and below the area that was stabilized, have more pressure, more stress. And they've done studies in the lab where they put pressure sensors in the discs above and below a fusion, and they found that there is more stress on the discs above and below. And that can cause concern to some patients that pressure is going to cause accelerated wear, accelerated degeneration, and eventually need for additional surgeries, like a domino effect in the spine. So that is a concern that a lot of patients have, the pressure that's placed on the levels above and below the fusion.
And what is normally your recommendation on somebody that's younger, if they're on borderline of maybe needing a fusion? What do you recommend in those situations?
Yeah, Every case is different, but we do prefer not to do a bigger operation on younger people because we want to preserve their motion and their functionality for as many years as possible. So we do try to avoid fusions on the youngest patients. But the truth is that sometimes it's necessary regardless of age. I mean, think of all the scoliosis patients that have a 10, 15 level fusion when they're teenagers. So we try to avoid it, and it has consequences, but if it's necessary, then it's necessary.
Talk a little bit about now the relationship between the attorney and the doctor. What information do you need from a plaintiff's attorney in order to do the best job you can for one of your patients that you've operated on?
Yeah, I think if I had to pick one thing, I would pick an accurate medical record, in particular, any prior medical records from before the injury. Because the last thing you want to do is review a case, look at the clinical history, look at the exam, look at the imaging studies, put it all together, have an opinion, and then you're in a deposition and, the day before he had the same 10 out of 10 pain. Now, there's no question that people who already have a problem in their spine can be injured legitimately and have a significant worsening. But if you don't know that, because I ask, patients when they come in, was there anything before? And if they say no, and if the attorney thinks the answer is no, and there's additional records, well, that can impact the credibility. And I think, honestly, credibility is the most important thing of all.
I would agree. You have to be credible. A lot of times you're going to be missing a piece of the puzzle, and that actually hurts you, gives the defense an opportunity to cross-examine you if you're not supplied with every medical record, especially, like you said, the priors. That could be devastating to a person's case. So when you're talking with your patients, how do you demystify what's going on in their spine and then recommend treatment options?
Well, part of it is what we talked about before, avoiding the medical jargon. I think fundamentally, patients are more than capable of understanding what their diagnosis is and what their treatment options. And in my practice, ultimately, I let the patients decide. I'm there to advise them, to give them my opinion, to tell them what the risks are, what the possible benefits are. But in the end of the day, it's very important for me that the patient decides whether or not to have surgery. So I have a computer screen in the room, and I pull up the MRI in front of the patient. I point on the MRI, say, okay, this is the disc, this is the bone, these are the nerves, this is what I see the problem is, this disc is out of place, it's pushing on this nerve. I feel like if you treat patients with respect and realize that, they may not be medical experts, but they're perfectly intelligent people, capable of making their own decisions, that they're going to make the right decisions for themselves. Part of the reason I like patients to make the decision is because I feel that somehow inherently they kind of know. They know when they need surgery. They know when something's wrong. And when you explain what's going on and explain the surgery and what you're going to do, I feel like the patient often does make the right decision about whether they should proceed.
And how do you determine whether it's going to be an outpatient procedure or an in-hospital procedure?
So most of my surgeries are outpatient. Patients who are outpatient get up faster, they walk more, they're more independent, they're not exposed to the possible infections that can be present in a hospital. There's a lot of benefits to getting your patients home in the same day. They can be with their loved ones. They have more autonomy. It can be very frustrating lying in a hospital bed waiting for a nurse to give you pain medicine because you're not allowed to take your own pain medicine in the hospital. So if it were me, I know I'd rather go home if possible. Now, there are some patients who it's just not safe, right? If someone had a heart transplant and diabetes and they're 78 years old, I'm not sure I'm going to send them home because they need to be monitored in the hospital. If they were to have an acute event, it would be much better to have immediate staff presence to address them. So it mostly has to do with the health of the patient. Although there are occasionally bigger operations where even if the person's, 25 and healthy. It's such a major operation with so much risk and so much recovery. I just say, look, you're just going to have to spend some time in the hospital until you recover.
Let's talk a little bit about artificial disc replacement. It's not that new, but it is relatively new, especially in this country. What is the purpose and what is an artificial disc?
Well, an artificial disc is a surgery where instead of taking out the disc and fusing the bones together, you remove the disc and put something mobile so you can maintain that degree of motion in the spine. And like any other medical technique or surgical technique, it has pros and cons. The advantage is you can maintain that small bit of motion that comes from that segment. There are some proponents of these disc replacements that feel that it can decrease the likelihood of needing surgery on levels above or below. So there are certain advantages to the disc replacement. There are, of course, certain disadvantages. You now have a mobile thing in there, which can wear. We know from hip replacements and knee replacements that they eventually inevitably wear. And you may say, okay, so it wears down. What's the big deal? The problem is that when they wear, they often release small particles of plastic that erodes the bone. That's a problem in the hip, and that's a much bigger problem in the spine. The other problem is the back of the spine has joints as well called facet joints. So if those joints are filled with injuries or arthritis or other problems, they're still there, so they can be a source of pain as well. So you have to really select the right patients for disc replacement versus fusion in order to get the best outcomes.
All right, we're going to sell you a little bit now, doctor. Let's talk about first of all, how long have you been practicing medicine?
I'm almost done with my 15th year.
Okay. And how many surgeries do you perform on an average year?
I've performed over my career thousands of operations.
Okay. And where do you specialize in?
I specialize in the spine. I think if there's any area that I've gravitated towards, it's been the minimally invasive surgeries. So when I finished fellowship, which was a traditional fellowship at the Cleveland Clinic, I immediately joined the practice that was, uniquely way ahead of the curve in terms of offering minimally invasive options. We had, different spine surgeons coming in just for special new techniques. I even traveled to Germany for a week to learn from some of the expert spine surgeons there. So I became, from the day that I started clinical practice as an attending, I became very adept at learning these new minimally invasive techniques, smaller incisions, tubes, cameras, things like that. And that's really been the major differentiator for me.
So if somebody's in need of spine surgery and they prefer a minimally invasive procedure with a doctor with your experience that's not only board certified, but is fellowship trained in neurology as well as biomechanics, how do they find you?
Well, I'm on the internet. You can Google me. You can type my name in. We've got a website, www.landaspine.com. I do the spine work in the practice. I have a partner, Dr. Hassan, who's a sports medicine trained physician who does work on shoulders, knees, things like that. And yeah, we're happy to take care of anyone who needs help.
Doctor, it's been a while since I've seen you. We're both a little bit older, but it's been a pleasure having you on the show. Thank you so much.
Thank you so much for having me.
And be well.